Hi, my name is Courtney. I'm a lead radiation therapist at Mass General Hospital in Boston, Massachusetts. So just one disclosure, Vision RT paid to send me here. Paid for my flight and hotel. So just a few things that we're going to go over today is just an outline of our surface imaging model at Mass General, some obstacles to treating extremity sarcoma patients, use of imaging in conjunction with Vision RT. We did an offline study that I'm going to go over some of the results of that, and how surface imaging assists in the accurate treatment of extremity patients. So at Mass General, we have 6 linear accelerators, 2 of which are Varian for our Electa. We have a proton center that has 2 gantries and 1 fixed beamline. On the photon side, we treat on average 190 patients a day. On the proton side, we treat 50 to 60 patients every day. We have one system in this photon side that's 2 cameras. All of our other systems, we have 3 camera based systems, 1 in the proton side and then 2 on the Linac side. Our 3 camera systems on the photon side are for breast and stereotactic and CNS. And then our Sarcoma machine just has the 2 camera systems, so it's kind of due for an upgrade. So I'll go over some of those limitations that we're seeing with the 2 camera system. So how Vision RT works, I think we all know at this point, but it uses the infrared cameras to image the surface of the patient's body, giving the therapist a real-time image of the patient on the table. It tracks the surface and compares it to the ideal image, be it that reference image or the CT DICOM that was imported, whichever you're using, across all 6 degrees of freedom. You can monitor the motion of the patient throughout the treatment by leaving it on. So soft tissue sarcomas are rare. They occur in 0.5 to 0.75% of all cancers. They arise in the extraskeletal connective tissue. The muscles in the adult human make up 40% of the body weight of a human, and the somatic soft tissues are about 50%. Soft tissue sarcoma can occur in any of those tissues, so they can basically occur anywhere in the body. They're most frequently present in the extremities first. So of all cancers, the American Cancer Center actually predicts only 12,000 new cases in 2017. So they are rare. We do seem to treat a lot of them at Mass General. So for us, this was a useful technology to implement. So as everybody knows, treating extremities can be extremely challenging given the wide range of possible motion of extremities. So we are fortunate enough at Mass General to have a dedicated immobilization room. So if a patient needs a complex custom immobilization device, as you see in these pictures, we will book an appointment an hour before their CT simulation, and the radiation therapist works with the physician to best position the patient to get that tumor compartment where they need to get all the beams at the best angles. So you can see here we'll use sort of accuforms, we'll use aquaplast sheets to immobilize different parts of the body. So we were noticing, we've been doing deep inspiration breath hold for a long time, and we were using Vision RT. We were able to decrease our treatment times on the breast machine from 15 minutes to 12 minutes after implementing SGRT. We were noticing that our sarcoma machine was running behind schedule on average an hour every single day in 20-minute time slots. So each of these sarcoma patients have these custom boards. They're big, they're awkward, they're heavy. It's also the thoracic machine, so you've got vac lock bags with these boards. You need 2 therapists to go in to change the room over by the time you get your patient in. It's just kind of a lot of lost time. So we were also observing that we had to film these patients every day. Our filming policy is any shifts more than 5 millimeters in any direction get repeated the next day to make sure that they're consistent. So we were seeing those consistently. So these patients were becoming pre-film every single day. We were just wondering how much intra-fraction motion we were seeing, as well as we knew the interfraction motion. So we were just wondering what gains we could get by implementing Vision RT for these patients. So we did a study. We took data from 16 patients. We did pre-treatment and post-treatment surface images, over 236 treatments for these patients. So we used the offline surface registration to quantify the inter and intra-fraction motion for these patients. I'm sure everybody knows this, but intra-fraction is the motion that happens from the beginning of the setup through the end of that fraction. Interfraction is what goes on for the entire patient's treatment, course of treatment. that sort of motion. So I'm just going to show you a couple of pictures. We were a beta site. If you guys learned from the last one, Master was a beta site for Vision RT. So these pictures are kind of old, and they show the older version, and it's a little more cumbersome to kind of see and understand. But you can see in this picture, this patient had a longitudinal shift of 1.1. The vert was almost 0.5. So those shifts had to be made, and it's a lot easier now with the bars to kind of see what direction you need to move in. But this was the older software. So this is just another shift. You've got a 0.9 on the vert, a long centimeter on the lat, kind of big shifts in all three directions. These were post-setup images taken, surface reference images. So this image you can see has a long of over 3 centimeters, which is huge. So depending on your record and verify tolerances, some might only have a 5 centimeter tolerance. You might not catch that with your record and verify, but Vision RT can check and catch those long, like gross errors. So from this, we deducted that our intrafraction motion is actually very small. We only had about a 1 millimeter adjustment in all directions, we noticed. So it's kind of assurance that our immobilization does work. Our patients, once they're set up, really aren't moving throughout the course of their treatment. The interfraction motion, however, had a 3D vector of 8 to 10 millimeters, which a lot of PTVs do a 0.5 to 1.5 isocentric around your CTV. So if you've got shifts of a centimeter, you could potentially be missing part of your target. So the random errors were 3 to 4 millimeters a day, and random errors are like those day-to-day errors. The systemic errors were the same, about 3 to 4 millimeters, and the systemic errors are sort of, if you're noticing every single day you've got that same longitudinal shift, it's just an error either with the setup or how the patient was immobilized. So from this data that we collected from this study, we decided this was definitely, we had gains that we could get from implementing SGRT for these patients. So what we do now, our current workflow, is we don't send over from the CT. Our CT doesn't have Vision RT. So on the very first day, we clinically set up to the patient's tattoos. We image using cone beam. Once we have a good image, we'll capture a surface reference of the patient. And then going forward, kind of day 2 and on, we will set up the patient the same way, aligned to the tattoos, make any prescribed shifts, and then we'll use Vision RT to make those fine-tune adjustments to get the patient right on track. We cone beam weekly for these patients. If we notice that an adjustment needs to be made on the film day or imaging day, we will take a new reference image after making that, and again, if it's more than 5 millimeters, we'll repeat the next day to check the consistency of that shift. So this is an example of what it might look like with the current software. On day 2, once you've set up your patient, you're going to have kind of these smaller shifts to fine tune and adjust. This is a 2 millimeter threshold. Our breast patients, we allow a 5 millimeter threshold. For the sarcomas, we do a 2 millimeter threshold for those. So we do cone beam for these patients. The evidence shows that just aligning to the bone isn't necessarily giving you a good indication of the soft tissue that you are treating. The surface really is more accurate. If you're treating a thigh and you just take KV orthogs, you aren't really going to be able to tell if that long bone is rotated, depending what your field of view is, if you can't see a joint or something like that. So we've really noticed a big difference in being able to align the patient appropriately using Vision RT in conjunction with cone beam. We're really able to align rotationally onto that soft tissue. I feel like using soft tissue to align to soft tissue just makes sense, which we were kind of like, what have we been doing all this time? But so the reference image is super important. Setting the reference image the region of interest is super important in how you do it. So if you're treating a forearm, you don't want to just set a teeny tiny region of interest around what you're treating. There's really nothing there except for kind of all the same size skin. There's no sort of irregularities in the skin. You really want to get like a joint in there. The wrist, an elbow, something that's different that they'll be able to read the surface image. That the surface image will be able to read. Otherwise, it just won't be reliable. You won't get good shifts. They kind of won't make sense, or they'll be jumpy because it's not really seeing a good thing. So I have an example here. The one sort of on the left isn't really a great one because of that. All that skin kind of looks the same. Also, there's like a part of the sheet at the bottom there. That's kind of a big mistake on the first day. Patient's cold, you'll want to cover them up, and then we leave and go to take the reference image, and you're trying to set your region of interest around like half a sheet that's covered up. So if it reads that, it's going to read that as part of the surface of the patient and throw off any adjustments that you have. So kind of the one to the right is a little bit better. You're going to want to kind of get that ankle in there to give it that irregularity so it knows what it's looking at. So this patient has a spindle cell sarcoma of the foot. So the therapist aligned to the tattoos, they're going to make any prescribed shifts. Once they make the shifts, this is a little video in real time so you can see how it works with my shaky hand. So the therapist, once they set them up, there's a therapist over on the side kind of going to read off the prescribed shifts. You can see the region of interest is set in that pink by the foot. So once we turn it on, which will happen momentarily. I was filming as they were setting the patient up. My editing skills aren't great. So you can see that lateral outlier is almost 3 millimeters. So the therapist kind of accidentally moves it in the wrong direction. You saw it kind of go red and then come back. They'll adjust for that way. So she's feet to gantry, so she initially was probably thinking it needed to go one way. That's why I kind of went into the red for a second, but it's very reliable, as you can see here. That's all green and good. So some other considerations using surface imaging for sarcomas is bolus. So like I said, our sarcoma room is the room that only has 2 cameras. It doesn't read superflab bolus. Sort of anything shiny makes the system kind of go wonky. It really can't see. So you can do one of 2 things. We tend to just set up the patient, use vision, and then put our bolus on. For breast patients, obviously that might not work if you're doing breath hold, but for the sarcomas, once they're in, we don't anticipate them moving a whole lot, so that's what we do. You could also cover it in paper tape. We noticed that worked pretty well, that once you get that shiny texture off, it can read that better. Swelling is our number 1 issue with sarcoma patients. They swell, they're going to swell. There's really no way day to day you've got the same therapist treating the patients that you're going to tell from day 1 the next day, can't really tell if they're a little more swollen or they less swollen. So our sort of rule of thumb, if you've got a shift on vision of 8 millimeters or more, that's high. That's like not normal to our workflow. If you make a shift on a cone beam day, you're going to recapture a reference image. So if you've got a shift of 8 millimeters or more, we're going to cone beam. Towards the end of these patients' treatments, we tend to cone beam a lot more frequently because, as you know, the longer the treatment goes on, the increased swelling gets. And we haven't really gotten a great way to get the surface image we just have to recapture a surface image every time to accommodate for that swelling. For photons, that's not a super big deal because you're able to still cone beam and align to that soft tissue. We don't have to replan these patients generally. You're able to make adjustments to compensate for that. Other considerations are for patients with dark skin pigmentation. So vision defaults to that mid-tone. I didn't even realize that was an option until kind of recently. We had a very dark skinned patient, and it was just really hard to see. The surface just wasn't capturing a good image. So we called our physicist, and he came down and was like, did you try the dark skin tone? Light dawns on Marblehead. So we didn't even know that was an option. And it's wonderful, and it's actually great because it's so hard to see that patient's tattoos too, that it's a nice sanity check that we are exactly where we need to be every day. I've never used the Fair. Mid seems to work for everybody else for us, but we recently got a TrueBeam machine that went live in December. We don't have OSMS. We still use the original Vision RT system. So as far as pitch, roll, and rotation goes, we're not really compensating for that for these patients. We do for our SGRT patients, but that's a whole different animal. But so we kind of are only focused on those top 3, vert, long, and lat, those straight directional issues. So I think in the future, OSMS just, to me, makes more sense as a therapist. I think our physicist sort of has some reservations on that, but that's something that we're not doing right now. So as far as if you have a big rotational shift, going in and trying to manipulate the patient but still trying to stay on their tattoos is something that we also kind of struggle with to listen to the vision or to stay on the tattoos. So generally we go with the tattoos. The cone beam will obviously tell us either way if we need to go back in and manipulate the patient. For system downtime, we rely very heavily on our SGRT. We trust it. So when it goes down, we go very far behind schedule because we film everybody to confirm, because we do make those small adjustments that could be up to 3 or 4 millimeters, and depending on how small or tight your PTV is, we are pre-filming those patients every day when the system goes down. So it doesn't happen too often, but when it does, we notice the machine falls behind. So overall, we find that surface imaging is very useful for a variety of anatomical sites. We don't use it on a ton. We use it on all of our breast patients: breath hold, Canadian fractionation, PBI, all of our right-sided, and our protons also use it on their breasts. We use it on SGRT for initial monitoring and setup check after the fact, and sarcoma, obviously. Like I said before, the intrafraction motion can potentially exceed PTV margins, so it can also assist in the intrafraction motion. Not everybody has those big boards with all of that fancy mobilization. Like, I've worked places that just use pillows under an elbow to treat something in the arm. So that obviously isn't going to mobilize the patient as well. So SGRT is nice that throughout the treatment you can kind of see if your patient is holding that position. We have treated 79 patients since 2013, sarcoma patients using SGRT. And we really think that it has been able to increase our accuracy and our throughput. We were able to reduce our treatment appointment times from 20 minutes to 15 minutes using this technique. It just really cuts down the amount of time not having to cone beam every single day. These are all the people that helped me out on this presentation. It's kind of fast. Sorry. Thanks.